Sustainable Sanitation and Hygiene for All Results Program is SNV's largest results-based funded program that is being implemented in select countries in Africa and Asia.
SNV has been working in water sanitation and hygiene for a long period of time, I think since 2010, and looking at how we can strengthen systems in order to ensure that people have access to basic services. The focus on sanitation was that we were seeing a lot of attention was being given to water, but perhaps sanitation and hygiene was being seen as the other relative and not getting as much attention. So we knew that even if you have access to safe water, if the sanitation is compromised, then the water is also compromised. And we thought during this call, which was made by DFID in 2013, the WASH Results Program, that it gave SNV an opportunity to demonstrate our approach, which is rural SSH4A, and at the same time, it gave us an opportunity to focus on getting as many people as possible into having safe sanitation and hygiene access.
SSH4A RP in Kenya is a collaborative initiative with the government of Kenya. It is being implemented in 2 phases and received generous funding from the United Kingdom government. The government of Kenya aims to achieve nationwide open defecation-free status by 2020. Kenya's enactment of the new constitution in 2010 was a landmark development with far-reaching implications on development in the water and sanitation sectors. Besides recognizing that access to safe and sufficient water and sanitation is a basic human right, it is also assigned the responsibility for water supply and sanitation provision to 47 newly established counties. Through funding by UK Aid, WASH Results Programme 1, SNV has partnered with 4 of these counties, namely Kericho, Homa Bay, Elgeyo Marakwet and Kilifi, in its SSH4A program to help the counties improve their sanitation status and achieve the ODF.
When we started the project, that was in 2014, the sanitation access on average across all the country programs that we were working in was about 40%. So that means for every 10 people, at least 4 of them had access. So 6 people did not have access to sanitation. And just for noting is that this information is based on rural sanitation. We're not looking at the urban side.
From 2014 through 2017, 220,000 people in Kenya gained access to sanitation and hygiene facilities, and 550,000 more people began washing their hands with soap after defecation. Open defecation rates fell from 48% to 18% over the 4-year period. So how has this achievement been realized?
In rolling out our interventions, we look at 4 main components. The first one is CLTS, under demand creation, behavior change communication, WASH governance and supply chain. So as we implement the approach, we look at villages on a case-to-case basis. There are villages where sanitation coverage is slightly higher and villages where sanitation coverage is low. So in areas where we have enhanced access, then we use behavior change communication to bring the village to speed in terms of attaining ODF. In areas where coverage is low, then CLTS becomes the most appropriate approach to ensure that access is attained at the end of the day. However, in many cases, we are able to combine the 2 approaches for optimal results.
CLTS as an approach for demand creation has a number of processes. So the first process is where we call community leaders, we engage with them, and then we also talk to community members. So that's what we call pre-triggering. So once we've introduced ourselves as health workers and what we are intending to do, from there now we go to the actual triggering process. There's rapport creation, there's the introduction that must also be done well, and then there's also, like we call it sheet calculation, and it goes up to the moment that now communities themselves decide now they want to stop open defecation as a community, as an entity, and now they come up with an action plan. So after that, this is also monitored. And then they agree that within a period of probably 1 month, everybody will be using a latrine.
Local authorities were also actively engaged in the CLTS program. This included the local chiefs and their Nyumba Kumi representatives who, after undergoing training, helped to spearhead the program in their respective areas.
Kabla ya hii program ya usafi ambayo SNV imetupeleka mbali, tulikuwa na magonjwa mingi sana. Hospitali yetu ilikuwa inapata wagonjwa kila siku ya kuendesha, typhoid na magonjwa mengine ambayo inahusiana na uchafu. Tumesaidiana na hawa volunteers ya afya na madaktari wa afya kuhakikisha kwamba kila nyumba kuna choo. Kila nyumba ikiwa na choo, tutapunguza magonjwa na watu watakuwa na afya bora.
The community response has been very good, and I would attribute that to the approach that we are using, because we have community-based promoters who are within the community, and after we train the promoters, they implement the project in their own communities.
At the end of the training, every promoter came up with his or her individual action plan with specific timelines on when to conduct pre-triggering, triggering and post-triggering activities within the given time frame. The enthusiasm was very high and all the promoters were excited in ensuring quality implementation and timely delivery of the individual targets.
In behavior change communication, we have developed a number of materials to be used, and one of them is a poster. We also have brochures on hand washing and a brochure on Safi latrine promotion. There are also flip charts, and we also have stickers. So these materials are used in different fora. For example, when we do the door-to-door BCC campaign, the primary material that we use is the brochure, and this brochure is used to facilitate conversation between the promoter and the household on one, proper hand washing steps, and two, the need to do so. If the household then doesn't have a hand washing facility, then they're encouraged to make one and use it at the end of the day. That comes as an action point after the end of this conversation.
Kokingonam kokakomyan nebo kecheken kechopchi kerichekab sukaruk. Kokingokakonam kwam kerichechoto konam kobar konyek. Lakini kokibaibai kora. Kebwan koit rusa kobwa lagok kokimuti kou ng'alekab toilet yu. Kokingokakoker kole ara yobe boisionik kokaikai orotwon wayandano. Kingokake kole orotwon man wayat koboiboenji akot ndong'ete sait ata nebo kemoi saa sita kwendi baka toilet akawek komie. Cham abochekeni yon nekit kobek beek aboris. Akokere toilet kora kit neu amu mokere inendet. Akere atilili. Ako kikechopchi kora mukono nomi yu. Kobokonome kityo keit akoat akonde taban. Kor yetar kasinyin koker akonyo. Ng'alekab toilet momi chito baibai, motindoi ng'al age tugul.
So as to get to the root cause of the difficulty in access to sanitation for vulnerable groups, SNV took a research in 2013 to try and find a long-term solution to the problem.
We started off with an action research in 2013 just to try and understand what the needs are and to come up with a product that would respond to these specific needs of the vulnerable groups. So we had looked at various segments of the community, and through that process developed a latrine that we call the Safi latrine. Safi latrine is an adaptation of the easy latrine that was developed by IDE in Cambodia. And it's basically made up of concrete components. They're concrete rings that look like the usual culverts that you would see, and a slab that comes over these rings. Now we responded to the needs that came out of this research, and there were about 4 needs that we saw. One was the issue of safety. People want a latrine that is safe to use, that them and their children can use. the issue of affordability, the issue of durability, that once I put this thing up, then it will give me service for very many years. And the other thing was smell and flies. People don't like a smelly toilet. We had further innovations coming up, especially for the elderly who have difficulty when it comes to squatting. And so the addition of pedestals and different types of pedestals. And additional modifications were also made for people living with disability, having different ramps and grabbers to enhance their movement within the facility.
The economic impact of the Safi latrine cannot be overemphasized, as many have benefited in value chain by building enterprises that have improved the living standards of their household.
I was a farmer, trying to help my parents in farming at home. Then I was called by a friend to come and train how to build a Safi latrine. And at that time, I joined the people doing the work, and I started that work commercially of building the Safi latrine. That was on the year 2015. I was trained on the technology and skill by SNV. Safi latrine has really improved my life, because that's where I get my income to feed my family.
When I started, I could even go for more than a month without installing even a toilet. Nowadays, the lowest I can is 3 in a month. And at the moment, it's really helping me because I have kids in school, and it's helping me to pay school fee, which I had a problem in paying before I ventured into this business.
Since watu ya SNV wakati walikuja kwa duka, wamenisaidia sana, kwa sababu wakienda kwa field wanajulisha watu macontainers zinazopatikana hapa kwa bei mzuri, tena kwa wholesale. Watu wanakuja kwa njia rahisi.
Sanitation as a function has continuously received low priority on resource allocation by the national government. With the function decentralized to the county governments, there was even more risk of sanitation being forgotten altogether when it came to the budgeting process unless proper structures were put in place to ensure the allocation of adequate resources. This, therefore, called for prioritization in planning and engagement of key decision makers to ensure gradual achievement of the constitutional right to a reasonable standard of sanitation. The SSH-4A program, therefore, chose to focus on 3 main pillars to support this process. Having an appropriate institutional framework through the domestication and enactment of the Environmental, Sanitation and Hygiene Bill at county level. Increased budgetary allocation through evidence-based advocacy. Improved planning and accountability through WASH forums and county and sub-county levels.
We were helping Ministry of Health and the team that I was leading, courtesy of the World Bank, also contributed to developing what is called County Prototype Environmental Health and Sanitation Bill. This prototype bill was to enable counties to fast-track enabling legal framework for sanitation. And I must say that this was and still remains a very complete document. So what the counties were to do was just basically to adapt them to their situation. SNV came up with a project to enable their 4 counties to domesticate the prototype environmental health and sanitation bills.
Several counties are all in the process of adopting into law the various hygiene and sanitation bills, with some at more advanced stages than others, with Elgeyo Marakwet and Kericho showing an increased budgetary allocation towards sanitation. Through concerted efforts by the SNV team, it has been proven that sustainable sanitation and hygiene can be made accessible for all using the SSH-4A RP strategies and approach. The SSH-4A Results Program has demonstrated that it is possible to achieve results within a short time frame. With the right support and prioritization, counties are able to ensure that the right to a reasonable standard of sanitation is achieved for all their citizens. Government investment in sanitation is critical for Kenya to achieve the ODF 2020 target. Together, we can make it happen.